Welcome to the Explainer. Today, we are diving deep into gallstone disease, or as you'll see it written, cholelithiasis. Our goal here is to cut through the noise and give you a super clear, high-yield guide that's perfect for your exams and for when you're on the wards. Okay, so here's our game plan. We'll kick things off with the absolute core concepts. Then, we'll get into how these stones actually form, what a patient with them looks like, how we nail the diagnosis, and finally, the really practical part, how we manage them step by step. All right, let's get right into it. Section 1, the core concepts. We've got to start with a solid definition and really understand why this is such a big deal in day-to-day medicine. So, at its most basic level, cholelithiasis is all about chemistry. It's what happens when bile, which is normally a liquid, gets out of balance. The stuff dissolved in it, like cholesterol and bilirubin, starts to precipitate out and form solid little particles. It's kind of like sugar crystallizing out of supersaturated water, but, happening inside the gallbladder. Now, to really get what's going on, you've got to know the lay of the land. So here's a quick look at the anatomy. The liver is the factory that makes the bile. The gallbladder is the storage tank. It holds onto the bile and concentrates it. Then when you eat, especially fatty foods, it squeezes that bile out through the ducts and into your intestine to help with digestion. It's right there in that storage tank, the gallbladder, where things usually go wrong. Now this is a really key point. Not all gallstones are the same. In Western countries, the vast majority, about 3/4 of them, are cholesterol stones, and that's going to be our main focus. The other quarter are what we call pigment stones, and they have a totally different cause. So we know what they are and what they're made of. But how do they actually come to be? Well, that brings us right to Section 2, the pathophysiology, or the how of stone formation. This slide lays out the 4-step recipe for making a cholesterol stone, and it's actually pretty logical. Step 1, supersaturation. Your bile just has way too much cholesterol in it. Step 2, nucleation. You need something for those cholesterol crystals to grab onto, a little seed to start the process. Things like mucus or calcium act as that seed. Step 3, hypomotility. The gallbladder gets a little lazy and doesn't squeeze properly, so the bile just sits there, creating a perfect sludge for crystals to clump together. And finally, Step 4, growth. Over time, those tiny microstones just keep growing and growing until they're full-blown gallstones. In this table right here, this is pure gold for your exams. It breaks down the key differences you need to know. See how cholesterol stones are all about that supersaturation we just talked about, and they're linked to things like obesity and high estrogen levels? Pigment stones, on the other hand, are from too much bilirubin, and you'll see them in patients with conditions that break down red blood cells, like hemolysis or in cirrhosis. Okay, let's switch gears from the how to the who. How does a patient with gallstones actually walk into your clinic? What do they complain about? What are we looking for? Okay, before we even talk about symptoms, here is probably the most important clinical pearl of this entire talk. Most people with gallstones have absolutely no idea. They are completely asymptomatic. The stones are usually just found by accident on an imaging scan done for something totally unrelated. This is so fundamental to how we manage them. But when people do get symptoms, they get what's called biliary colic. And honestly, that name is a little misleading because it's not a colicky, cramping, come-and-go pain. Nope, it's a constant, deep, intense aching or pressure-like pain, usually right up under their ribs on the right side. So these are the key features you're listening for in the patient's story. That steady pain in the right upper quadrant, sometimes shooting through to the back or the right shoulder. It usually lasts for a few hours, and here's the classic trigger. It often starts an hour or so after eating a fatty meal. A lot of patients will also feel nauseous, they might vomit, and they often get really sweaty with it. All right, so we have a patient with a story that sounds just like that. Our suspicion for gallstones is high. So how do we prove it? Let's walk through the workup, from blood tests all the way to imaging. So first things first, we're going to draw some blood. The CBC can give us a hint if there's inflammation going on. The liver function tests, or LFTs, are super important because they can tell us if a stone has moved out of the gallbladder and it's now blocking the main bile duct. And we absolutely have to check an amylase to make sure we're not dealing with gallstone pancreatitis, which is a very common complication. But here's the thing. Labs can point us in the right direction, but they can't actually diagnose the stones. For that, we need to see them. And this image here is the money shot. It's a classic ultrasound. That bright white spot is the gallstone. And see that dark streak behind it? That's called an acoustic shadow, because the sound waves can't pass through the stone. When you see that bright spot with the shadow behind it, you've found a gallstone. So when it comes to finding gallstones inside the gallbladder, I want you to remember this. Ultrasound is the undisputed champion. It's the king, it's fast, it's cheap, there's no radiation, and it is incredibly accurate. We're talking over 95% sensitivity and specificity. It is the first and best test, period. Now, while ultrasound is the go-to, sometimes you'll see a really important finding on just a plain old X-ray. What you're looking at here is something called a porcelain gallbladder. See how the whole wall of the gallbladder has turned to calcium? It literally looks like a piece of porcelain. And listen up, because this is a massive exam topic. If you see a porcelain gallbladder, your brain needs to immediately scream cancer risk. The association with gallbladder carcinoma is really high. Because of that risk, finding this is an absolute game changer. It's one of the few times we will take out a gallbladder even if the patient has 0 symptoms. Okay, let's bring it all home. We've gone through the what, the how, the who, and the diagnosis. Now for the final, most practical piece. What do we do about it? Let's build a clear framework for patient management. So, picture this. That ultrasound report comes back and it confirms gallstones. What is your very next move? Well, the entire management plan, everything we do from here on out, hinges on the answer to one simple, crucial question. And this slide right here is that fork in the road. On one side, you have asymptomatic gallstones. The general rule? Leave them alone. Just observe. The odds of them ever causing a problem are pretty low. But on the other side, if those stones are causing symptoms, that classic biliary colic, then the rule is treatment because the risk of more attacks and complications is high. And treatment means surgery to remove the gallbladder, a cholecystectomy. But you know in medicine, there are always exceptions to the rule, right? And these are the ones you have to know. We already talked about the big one, porcelain gallbladder. We'd also take out the gallbladder for really big stones. We're talking over 3 centimeters, or in patients with certain gallbladder abnormalities from birth. These are all about managing a higher risk of cancer down the road. In one last really important point, what if you have a patient who has gallstones, but their pain just isn't quite right? It's not the classic story. You have to remember, just because 2 things are true at the same time doesn't mean one caused the other. You have to think about other causes for their pain, like an ulcer or GERD or even their heart, before you just blame the gallstones. And that brings us right back to our central theme, the one question that drives everything. Are these stones actually causing you any symptoms? Making that distinction between symptomatic and asymptomatic disease, that is the absolute key to managing gallstone disease safely and effectively. If you can master that concept, you've mastered the fundamentals.